Hi, this is Dr. Rybinnik. Today we'll review headache, specifically recurrent and chronic headache. Thunderclap headache is a topic for another day. This video is rated MS for medical students due to basic concepts, clear language, and case-based examples. Medical student participation is advised. I have no relevant financial conflicts to disclose. The case included in this video is modified for teaching purposes. In this video, we will start with the case, discuss the anatomy of pain, go over the differential diagnosis of primary headache, and then treatments for primary headache. We will then switch gears to the discussion of the differential diagnosis of secondary headache syndromes, and we'll conclude with a summary. So keep your hands and feet inside the vehicle at all times and enjoy the ride. In headache cases, neurological examination and workup can be normal, so the history is everything. Today, we're seeing a previously healthy 18-year-old woman who now developed headaches. Her headaches began in the sophomore year of high school at age 15. At first, they were infrequent, but now she says, "I get headaches all the time. I rarely remember a time without one." That's the reason for her visit. How bad are the headaches on a scale of 1 to 10, with 10 being the worst pain you've ever felt?
Most of the time, the headaches were manageable, usually between 1 and 3. Occasionally, they would go up to a 5 or 6, but even then, I was able to manage. As I got older, they seemed to get worse. The few headaches that were bad enough to send me to the ER were probably an 8 or more, but I never experienced a true 10 out of 10 headache.
What was the quality of pain? Throbbing, pressure, sharp, zapping?
It was usually some sort of throbbing and pressure, but I would also get sharper pains.
Which part of the head hurt?
Mostly the left side of my head in the front, but the headaches often switch sides. The pain sometimes would also be in the back of my head.
Did you notice any incident like head trauma or psychological stressors that started the headaches?
No, not that I'm aware of.
Does anything trigger a headache or make it worse?
Yes, definitely. Sometimes bright lights. Sunlight would definitely make it worse. Hate light, never go out in the sunlight. I would be a vampire if I could. Although I also get a headache if I'm hungry or sleep poorly.
From the time the pain starts, typically how long would it take for it to become the strongest?
Sometimes the headache would slowly get worse over a couple of hours, but it would worsen in an hour and then sort of stay at the same level, like a dull aching. My headaches would last anywhere from multiple hours to a few days even. I remember going to bed with a headache and waking up with it.
Before, during, or after the headache, have you ever experienced sensitivity to light, sound, smells, to the point where you had to turn off the lights and go into a dark room to rest?
Yeah. Usually it was light sensitivity, but not every time. Sometimes I got nausea. I think one of the few times that I got it was with very extreme pain. Also, my vision sometimes gets blurry and I have difficulty focusing.
I'm going to list a number of neurological symptoms and you let me know if you've ever felt these with a headache. Weakness, numbness, speech changes, disorientation, vision changes, such as a big blind spot or geometric patterns in your vision, dizziness or room spinning, or any trouble with balance.
No.
And what about face swelling, eye tearing, or redness, or droopy swollen eyelid?
No.
Is there a particular time of day when headaches happen, and do they wake you up from sleep?
I usually start to pay attention to the pain in the afternoons, but it happens at any time. The headache does not really wake me up, but as I said before, I sometimes notice it when I wake up.
Is there a particular time of the year when headaches are the worst?
Not really, but when I don't have school, I usually don't get headaches.
I see. What makes your headaches better? Do you use any medications?
I would try to take Tylenol or Excedrin, but it never seemed to help. Most of the time I didn't take anything and would just ride it out. When the headache gets bad, I would turn off the light and take a nap. That made me feel better.
Now, besides the headaches, how are you feeling otherwise? Do you experience fevers, weight changes, joint pains, rashes?
don't feel sick.
Do you feel like your headaches interfere significantly with your life?
Yes. Sometimes I avoid going outside during the day because I know that the bright sun triggers my headaches.
And what about your school performance?
I can still keep up with my classes. I've always gotten A's and B's.
Does anyone in your family suffer with headaches?
Yes. My mother and my uncle have headaches.
So that was a nice and detailed history. You may have noticed that we focused on the description of pain, quality, severity, location, timing, which refers to time to peak, duration, and relationship to circadian rhythm, precipitating relieving factors and triggers, frequency, and relationship to seasons or major physiological events like menstruation, and any associated symptoms, systemic or neurological. On examination, her vitals are normal, and so is her body mass index. Mental status is normal, and otherwise there are no focal neurological deficits. So the screening neurological exam did not yield any useful findings, except what additional exam maneuver may be helpful in the diagnosis of headache? What's that? Fundoscopy? So we have to assess for papilledema. Here's an illustration of the normal fundus. Optic disc is in the middle, with the most central portion called the optic cup. Retinal vessels emanate from the optic nerve head. In the center of the retina is the macula, the area of maximal visual acuity. These structures are also visible on the photograph of the fundus taken through the pupil. You can even make out the retinal veins. They're generally thicker, darker in color, and have narrower central reflex. They reflect less light than arteries. And of course, this is not a static but a dynamic picture. Check out these venous pulsations. Well, the fundus is a beautiful mystery of the universe, but why do we care? Because of this. Blurred disc margin, loss of major vessels, splinter hemorrhages. This is papilledema, a sign of elevated intracranial pressure, but really a sign that you're not dealing with a benign headache. This particular example patient has cryptococcal meningitis, which is causing hydrocephalus. So, our 18-year-old previously healthy woman with family history of headaches developed episodic, moderate unilateral throbbing headaches, which are frequent, lasting hours, associated with photophobia and nausea, worsened by lack of sleep and missing meals, improved with rest and sleep. Neurological and systemic symptoms and signs are absent, and there's no papilledema. I'm going to ask you a question that I bet nobody has ever asked. Ready? What is the localization of the lesion causing her headache? Well, let's spend a little time on the anatomy of pain. Or painful anatomy? Yeah, that sounds about right. Here's an illustration of a sagittal cut through the middle of the brain with the patient looking to your left. Let me orient you. Medulla. Pons with trigeminal nerve exiting. Fourth ventricle between the pons and the cerebellum. Thalamus. Hypothalamus. And the cortex. We will use migraine as the prototypical headache to review the headache networks. There are 4 major systems involved in head pain. Trigeminal vascular system, trigeminal cervical complex, the diencephalon, thalamus and hypothalamus, and the cranial autonomic system. Now this next part is a little technical, so bear with me. Trigeminal afferents that innervate cranial structures, vasculature, and the dura, together with the cervical afferents and the occipital nerve that innervate the back of the head and neck, converge in the trigemina cervical complex. The TCC is located in the brainstem and upper cervical cord. That trigeminal nucleus is really long. Rostroventral medulla, locus ceruleus, periaqueductal gray, and the diencephalon modulate trigeminovascular sensory information and pain as it travels to the cortex. Kind of like piles of rocks constructed on beaches to block strong waves. The parasympathetic pathway is most likely responsible for the autonomic symptoms, like salivation and lacrimation. And of course, there are descending modulatory projections. I'm being deliberately vague and simplistic here since the pathway is much more complicated and not well understood. But instead of debating the finer points of headache anatomy, I would just like to use it as a clinical mnemonic of sorts. Trigeminal vascular system innervates the vessels. That means any injury to the vessels of the head and neck, small or large, veins or arteries, can be painful. Trigeminal cervical complex in the brainstem is a vital area for migraine. It mediates neck discomfort, head pain, and autonomic symptoms like lacrimation, salivation, eyelid edema, pupillary changes, by way of cranial autonomic system and parasympathetics. Hypothalamus is responsible for the circadian rhythm and homeostasis, so it mediates altered sleep-wake cycles and seasonal regularity seen with some headaches, food cravings, thirst, increased urination, and yawning. Oh my god, have I been talking for 9 minutes and you're still here? Wow. Well, let's keep going. Now, thalamus is really cool. It's the pain gateway. It processes sensory inputs and mediates pain thresholds. So sometimes non-painful stimuli, like brushing the scalp or moving the eyeballs inside their sockets, can be perceived as painful. This phenomenon is called allodynia. And on top of it all, the very last word in information processing is the marvelous cortex. So patients with migraine often complain of sensory derangements, photophobia, other visual disturbances, sensory changes, mood and emotional changes like irritability, and cognitive slowing, especially in the domains of language, memory, and attention. So remember, trigeminal vascular system, trigeminal cervical complex, diencephalon, thalamus and hypothalamus, and cranial autonomic system. That's that for anatomy. Our patient had frontal and posterior head pain, photophobia, nausea, cognitive slowing, some alteration of sleep-wake cycles, but no autonomic symptoms, seasonal regularity, or food and water cravings. So, back to my original question, which areas of the brain are activated with your headaches? If you need a refresher, rewind the video. Painful anatomy behind us, let's tackle the pathological differential diagnosis. There's a reason why headache is a challenging topic. International Headache Society classifies headache disorders into 3 main categories, with 4 subsections of primary headaches, 8 for secondary headaches, and 2 for painful neuropathies. And each subsection also has sub-subsections. 84 distinct disorders, and don't even get me started on the appendix. We will just discuss a representative sampling. Our differential includes primary headache disorders, migraine with and without aura, and trigeminal autonomic cephalalgias, of which cluster headache is the prototypical example, neuropathies and facial pains, including trigeminal neuralgia and postherpetic neuralgia, and potentially the most dangerous category of secondary headaches. And here we are primarily talking about disorders of intracranial pressure regulation, like idiopathic intracranial hypertension, also known as pseudotumor cerebri, lesions of the intracranial and extracranial vessels, like arteritis, dissection, cerebral venous thrombosis. Remember that vessels are innervated by the trigeminal vascular system, so vascular lesions may be painful. Intracranial non-vascular lesions, here we usually mean mass lesions like tumors. And the disorders of the cranium, neck, eyes, ears, nose, sinuses, and teeth. Temporomandibular joint dysfunction and sinusitis come to mind. This, of course, is just a partial list. Some of these disorders are quite dangerous and should not be missed, so we need to snoop for red flags. And S.N.O.O.P refers to a mnemonic that summarizes features emblematic of a headache with a secondary cause. S stands for systemic symptoms, like fevers, known malignancy, immunocompromise, and pregnancy. Why pregnancy? Well, pregnancy is associated with a prothrombotic state with increased risk of intracranial clotting. N stands for neurological deficits, like papilledema, focal deficits, impairment of alertness or cognition. The first O stands for onset sudden, or a new headache. You've learned that subarachnoid hemorrhage causes the worst headache of life. The problem is that every person presenting to the emergency department with a headache has the worst headache of life. That's why they're in the emergency department. and most of them don't have subarachnoid hemorrhage. So it's less about presenting with the worst headache of life and more about the fastest headache of life. When headache peaks within a minute, that's very concerning. The second O refers to onset of headaches in older people. With age above 50, the risk for secondary headaches increases. P stands for pattern change and provoking maneuvers. We get concerned when headaches from earlier in life change character and develop new associated symptoms. It's also concerning if headaches become positional or worsen with Valsalva, coughing and straining. Why? Well, that potentially signals a disorder of intracranial pressure regulation. So does our patient have any concerning S.N.O.O.P signs? Is she S.N.O.O.P positive? She's young and healthy. She doesn't exhibit any neurological deficits. Onset of her headache is not sudden, and her headache does not peak within a minute. I guess you can consider her headaches as new? So maybe, but we could probably agree that she's very likely suffering from a primary and not a secondary headache. And speaking of primary headaches, let's review the diagnostic criteria. Migraine. You need at least 5 attacks. Pain should have at least 2 characteristics, including unilateral, pulsating, and at least moderate, and may be aggravated by physical activity. Headache typically lasts hours, but may even last up to 3 days. Migraines often have associated symptoms like nausea and vomiting and photo and phonophobia. Now, here's an important point. The headache phenotype that I described here is not exclusive to migraine. In general, the clinical description of headaches is not very specific to a particular diagnosis. So that's a good reason why the diagnostic criteria for every primary headache disorder require exclusion of secondary causes. Brain imaging should be normal before you call something a primary headache. About 1/3 of individuals with migraine experience an aura. During a migraine, a wave of spreading neuronal depression gradually travels through the cortex from the occipital lobe forward. And this depression is associated with transient decrease in cortical blood flow. So the patient develops transient neurological deficits, vision disturbances, then sensory deficits, then motor deficits, and language disturbance. Not all patients experience all the symptoms. Classical aura, for example, includes only the visual symptoms. And by the way, the progression times between these different neurological deficits illustrated here are only approximations. In order to diagnose migraine with aura, we need at least 2 attacks. And the deficits must be fully reversible. Less than 5 minutes duration is too brief for an aura, and deficits lasting over an hour should raise concern for a structural lesion, like a stroke. So the appropriate duration for an aura is 5 to 60 minutes. The attack also needs to have at least 2 of the following characteristics to qualify as an aura. Aura symptoms spread gradually and occur in succession. Symptoms are typically unilateral and positive. Think tingling more than sensory loss. Aura can certainly occur without a headache, but it should be associated with a headache sometimes. Cluster headache is the other prototypical major primary headache. To diagnose cluster, at least 5 attacks are necessary. The attacks should be severe, and in this disease in particular, severe is really an understatement. Cluster pain is universally unilateral. It's locked to a particular side of the head. This is unlike migraine, since migraine attacks ultimately affect both sides in about 40% of the patients. Cluster pain centers around the ophthalmic division of the trigeminal nerve. Duration of a cluster is typically longer than 15 minutes, but less than 3 hours. The autonomic system is responsible for corner, small pupil with an eyelid droop, eyelid edema, and lacrimation with conjunctival injection. The sense of restlessness and agitation is likely mediated by the hypothalamus. And finally, clusters are generally short, so they may be quite frequent, occurring once every 3 hours. So let's summarize. What are the most important differences between cluster and migraine? Cluster escalates more rapidly than migraine, on average less than an hour for cluster versus several hours for migraine. Cluster is typically side-locked, prefers one side of the head, while migraine often switches sides. Clusters are shorter, less than 3 hours, while migraine may last for hours to days. Both migraine and cluster may have autonomic features, lacrimation, salivation, Horner, but these are more common and prominent in cluster. Restlessness and circadian pattern are also features particular to cluster. And as obvious as this sounds, cluster headaches cluster. Because of shorter headache duration, cluster patients may have more than one headache per day. Now let's get back to our patient. Her headaches peak in 1 to 2 hours. Headaches switch sides. They last hours to days and are associated with photophobia and nausea. Without autonomic features, restlessness, or circadian pattern, what is the most likely diagnosis? Did you just say migraine? Committing to a diagnosis even without a single brain scan? That's brave. Well, you're right. For young patients who meet migraine criteria and have no red flags, MRI is not absolutely necessary. But I would say that a fair number of neurologists may perform one at baseline. What treatments would we suggest for her at this point? When it comes to primary headaches, there are many available treatments. As my mentors would say, the reason we have so many treatments is because there's no clear winner. Treatments for primary headaches generally fall into two categories: abortive and preventative. In certain cases, there are also transitional therapies to bridge a patient from acute treatment to chronic prevention. Abortive therapies include nonspecific analgesics like Tylenol and ibuprofen, triptans, alone or in combination with nonsteroidal anti-inflammatory drugs, NSAIDs. Triptans are selective serotonin agonists, specifically acting on the 5-hydroxytryptamine 1B or D receptors. They were designed specifically for migraine treatment and are considered first line for now. B in the name of the receptor stands for blood vessels, so triptans may cause vasoconstriction and potentially exacerbate already lowered blood flow in the brain. Triptans are at least theoretically dangerous in patients with migraine with neurological deficits or cardiac disease, although the risk of stroke and heart attack was not increased in large population studies. Ditans are selective 5-HT1F receptor agonists. Think triptan level efficacy minus the cardiovascular concerns, but plus potential for sedation. Gepants are calcitonin gene-related peptide or CGRP antagonists. CGRP antagonists are the new kids on the block, and they promise lower cardiovascular and CNS side effects. But time will tell. Oral preparations may be administered at home, but in a hospital or clinic setting, we may offer 100% oxygen therapy, which works best for cluster headache. Sphenopalatine ganglion and occipital nerve blocks may also work for intractable primary headaches. If what I just said made no sense to you, allow me to illustrate. This is the headache network. Occipital nerve stimulates trigeminal cervical complex, so blocking it aborts a primary headache. Sphenopalatine ganglion is here. Stimulation of trigeminal afferents can result in cranial autonomic outflow. Inject some anesthetic here, and that may also abort a primary headache. Parenteral medications are also useful, especially in the emergency department setting. Drugs like intravenous NSAID ketorolac, metoclopramide, which blocks serotonin receptors in the medulla, antiepileptics like valproic acid, and even glucocorticoids. The goal of all abortive treatments is to ultimately inhibit the cervical trigeminal complex. If you think there are too many abortive therapies, buckle up. Here come preventative therapies. In general, more than 4 disabling headaches per month qualifies a patient for preventative therapy. First, lifestyle modifications and other non-pharmacological interventions. We're talking quality sleep, regular meals, and avoidance of known triggers, like alcohol. Headache sufferers are also asked to keep a headache diary to monitor headache frequency, severity, and triggers. Out of antiepileptics, topiramate has the best evidence. Side effects of topiramate include weight loss, cognitive slowing, and renal stones. It's a weak carbonic anhydrase inhibitor. Antihypertensives include beta blockers like propranolol, calcium channel blockers like verapamil, and angiotensin receptor blockers like candesartan. With respect to antidepressants, there is evidence for tricyclics like nortriptyline and serotonin norepinephrine reuptake inhibitors, or SNRIs, like venlafaxine. Tricyclics have potential cardiotoxicity, antihistaminic effects, sedation, and anticholinergic effects, dry mouth, constipation, urinary retention. Injectable CGRP antagonists are new, and they're attractive because they have faster onset of action, robust efficacy, and monthly or quarterly dosing. But because they are new, the side effect profile is still evolving. These drugs, along with botulinum toxin injections, seem to be more effective in treating chronic migraine, or headache because of medication overuse. Makes sense, doesn't it? If you have constant headaches, you will constantly take abortive medications to alleviate them, and thereby causing paradoxical worsening. And finally, medical marijuana has some supporting evidence in headache treatment as well. Is your head spinning at this point? Yeah, well, here's some useful tips for treating primary headaches. Start by optimizing abortive therapy. Then, add transitional therapy to bridge acute treatment with tailored preventative treatment. For a significant number of patients, a combination of a triptan and an NSAID taken early, within 2 hours of symptom onset, should abort a headache or other bothersome migraine symptoms. For patients with significant cardiovascular risk, stick to non-triptan alternatives like ditans or gepants. How do you know you've met your goals? That their abortive therapy is optimized? Ask the following questions from the Migraine Assessment of Current Therapy questionnaire. Does your medication work consistently? Does the headache pain disappear within 2 hours? Are you able to function normally within 2 hours? Are you comfortable enough with your medication to be able to plan your daily activities? Say your therapy is not optimal. Patient continues to have frequent headaches. That patient continues to take abortive medications, which paradoxically causes more headaches. This phenomenon is called medication overuse, and it's so difficult to treat. It's best to just prevent it. How do we do that? Well, limit the use of a particular abortive drug to less than 10-15 doses a month, vary drugs, and up-titrate preventative regimen. By the way, a short-term bridge of a medication like glucocorticoids may buy you some time until preventative regimen becomes effective. And speaking of prevention, the choice of agent largely depends on comorbidities. Hypertension, cardiovascular risk factors, beta blockers, calcium channel blockers, angiotensin receptor blockers are all reasonable. Topiramate can treat obesity and certain seizures, tricyclics and venlafaxine can treat depression, and amitriptyline sedating effects can help with insomnia. Headaches during pregnancy. Nobody really knows what to do with headaches during pregnancy. There's limited safety data. Most would choose non-pharmacological approaches, like nerve blocks. Beta blockers, tricyclics, and calcium channel blockers may be safe, but headache neurologists feel uncomfortable using most prescription medications in pregnant patients. But one thing is clear. Anticonvulsants, especially valproic acid, should definitely be avoided. They're potentially teratogenic. I should also mention that everyone may benefit from lifestyle changes.
Everybody's gonna know, everybody's gonna see. Everywhere I turn, all eyes on me. Float like a butterfly, sting like a bee. 'Cause everywhere I go, all eyes on me.
How about we start sleeping 8 hours a night and avoid missing meals? And back to our case. Our patient certainly had over 4 headaches a month, and the headaches were moderate enough to interfere with her daily life. She was treated with ibuprofen and triptan for abortive therapy. The lifestyle modification didn't help matters, and she was offered topiramate, which she unfortunately couldn't tolerate because of cognitive slowing. Fast forward 3 years. She's now 21 years old. Her migraines have improved. In fact, she cannot remember the last time she had to take ibuprofen. She was diagnosed with polycystic ovarian syndrome and started on oral contraceptives. Over the past 3 days, she complained of moderate intensity, constant mid-frontal headache. There's no photophobia, no nausea, no recent illness. This is very much unlike her migraines. Her family noted that her affect has become somewhat flat. She doesn't seem to be concerned about her difficulties using her left hand. Left upper extremity apraxia and mild weakness was confirmed with neurological examination. Migraines can certainly evolve and change, but this is something very different. She has new neurological deficits, and the pattern of her headaches has changed. We're now concerned for secondary headache. Let's broaden our differential. And I'm talking about adding diseases like idiopathic intracranial hypertension, or pseudotumor cerebri, mass lesion, tumor, giant cell arteritis, arterial dissection, and cerebral venous thrombosis. And for good measure, let's add trigeminal neuralgia. Not all these diagnoses apply in this case, but we have to cover the headache's greatest hits, if you know what I mean. Idiopathic intracranial hypertension is first. In the first part of the talk, we focused on describing headache features in great detail, but headache phenotype never excludes a secondary cause. The clinical features that are often associated with migraine and cluster are not specific. There's a good reason why the diagnostic criteria for the primary headache disorders require exclusion of secondary causes. In idiopathic intracranial hypertension, the headache description is generally unhelpful, with one exception. Headache may be precipitated or worsened by maneuvers that increase intracranial pressure, like Valsalva. There will be objective signs of elevated intracranial pressure, like papilledema, but overt focal neurological deficits should be absent. Idiopathic intracranial hypertension also goes by the name pseudotumor because it acts like a mass lesion, causing high-pressure headaches. But focal neurological deficits are more likely with tumor than pseudotumor. Abducens nerve palsy is the only deficit permitted. The theory is that with increased intracranial pressure, there's downward displacement of the brainstem that stretches the sixth nerve. The nerve is then compressed against the petrous ridge of the temporal bone. So sixth nerve palsy is a false localizing sign. The problem doesn't necessarily originate in the sixth nerve. Instead, in this case, a global increase in pressure gets transmitted to the sixth nerve. Lumbar puncture is necessary to confirm elevated intracranial pressure. And brain lesions causing mass effects should be excluded with imaging. Easy. But you may ask, what about all the epidemiological features that I learned in med school? Younger patients, females, obesity, vitamin A use. Those associations are true, but they're neither specific nor sensitive. So be careful about using them in the diagnostic process. Pseudotumor aside, let's talk about real tumors. About 1/3 of patients with brain tumors present with a headache. Headache phenotype is once again nonspecific, but just like with pseudotumor, headache may worsen with a change in position, Valsalva, or exertion. Don't count on those features helping you with the diagnosis because they occur rarely. What is more helpful, in fact, is that with tumors, headache is rarely the only symptom. 1/3 of patients with tumors may have a headache, but only 2 in 100 report a headache as the only symptom. There are essentially 3 factors that predict tumor headache: tumor size, tumor location, and the rate of tumor growth. As you can imagine, larger tumors located in the posterior fossa with rapid rate of growth tend to be more associated with headache. But like I said, in the majority of patients, it's not the headache, but the additional symptoms that will lead to the diagnosis of tumor. Those symptoms include focal neurological deficits, signs of elevated intracranial pressure, like papilledema, endocrine disturbances, in the case of tumors affecting the sella, and seizures. But ultimately, tumors are really diagnosed by imaging, so let's take a look at some examples. Here are 2 axial slices. T2 on the left, T1 with contrast on the right. Patient is looking towards the top, and the patient's left is on your right. Notice the confluent subcortical finger-like projections of vasogenic edema, and that edema surrounds multiple well-circumscribed enhancing mass lesions at the gray-white junction. This is a great example of metastatic disease, and in this case, lung cancer. Metastases are by far the more common brain tumors in adults. Lung and breast, but also melanoma, renal cell carcinoma, and gastrointestinal malignancies. Just remember, in a patient with known cancer, a new headache is a red flag. Moving away from metastasis to primary brain tumors, here's an example of a common primary brain tumor. Axial T1 with gadolinium on the left, And flare, T2 with CSF subtracted, is on the right. CSF cleft makes this mass extraaxial. It's homogeneously enhancing, it has a dural tail, and some mild vasogenic edema. Yep, this is a meningioma. Meningiomas are usually slow-growing, so headache occurs less often than, say, with rapidly growing tumors like gliomas, and headache occurs in about 1/3 of these patients. This is another meningioma, but this time in the posterior fossa. Here is that homogeneously enhancing dural mass at the cerebellopontine angle. Posterior fossa tumors are generally more rare, but posterior fossa is a confined space, which means there's higher potential for compression of brainstem structures in the fourth ventricle, and compressing the fourth ventricle may cause hydrocephalus. Up to 80% of patients with posterior fossa tumors have headaches. Surprised? No, not at all. We talked about metastasis and meningiomas. Now here's a lesion that's identified by T2 hyperintensity, or vasogenic edema. The appearance on MRI is fairly nonspecific. This turned out to be a low-grade glioma. In general, because low-grade gliomas are slow-growing and supratentorial, they cause headache less frequently. Seizures are more common with these lesions. Now, increase the rate of growth, enlarge the size, and you're dealing with a high-grade glioma. Look at the extensive vasogenic edema and rim enhancement. And one more relatively common primary brain tumor, pituitary adenoma. The image on the left is a T2 axial cut through the cella. Patient is facing the top of the slide. The image on the right is a coronal T1 with contrast. Patient is facing you. There's a heterogeneous T2 hyperintense mass about the size of a golf ball that expands the cella. These tumors usually present with visual symptoms from compression of the optic nerves and the chiasm, but also endocrine symptoms. About 2/3 of patients also have headaches. In this case, the mass is invading the left cavernous sinus. And cavernous sinus contains cranial nerves 3, 4, and 6 for ipsilateral eye control. This patient has disconjugate gaze, and the left eye appears abducted. So to briefly summarize this section, there's a variety of tumors that cause a headache. Most common tumors in adult are metastasis, meningiomas, gliomas, and pituitary adenomas. The larger size, rapid rate of growth, and posterior fossa location are predictive of headache. So at this point, we discussed intracranial pressure dysregulation, intracranial non-vascular lesions. Let's switch to intracranial and extracranial vascular lesions. And we will start with cerebral venous thrombosis. Headache is the most common presenting symptom of cerebral venous thrombosis. Thrombosing venous sinuses cause cerebral edema and increase intracranial pressure, so once again, headache is rarely the only finding. Cerebral venous thrombosis patients also experience nausea and vomiting, visual field defects, seizures in about 25%, focal neurological deficits, altered consciousness, and cranial nerve palsies in less than 1 in 5. Cerebral venous thrombosis really presents as 4 distinct entities. Headache, with or without symptoms of intracranial hypertension, the most common presentation. Focal syndrome with neurological deficits and perhaps seizures. These are patients where venous thrombosis causes a stroke. Diffuse encephalopathy or coma, probably from thrombosis of the straight sinus that drains the structures comprising the reticular activating system. And cranial neuropathies and painful ophthalmoplegia, especially with thrombosis of the cavernous sinus. Alright, next up, extracranial vascular lesions, spontaneous cervical arterial dissections. When it comes to dissections, headache and cervical pain are most common, followed by Horner and transient monocular blindness. What's wrong with this patient? Yes, there's ptosis and a small pupil on the patient's left. This is Horner syndrome. Looks very subtle, doesn't it? You'll never find it unless you look for it. Pulsatile tinnitus may happen because the ear actually picks up turbulent flow within the dissected artery. And cranial nerve palsies could result from nerve ischemia with compromised blood supply. Those last 2 complications are rare. A dissection is a tear of the fragile intimal layer. A painful tear. A tear that causes the formation of an intimal flap. The blood then penetrates into the muscular portion of the vessel wall and forms an intramural hematoma. You can actually visualize this process with non-invasive vascular imaging. Here's an MRI of the neck with contrast and the patient is facing you. Here's the normal left internal carotid artery. Now look at the right. The dissection is causing the normal vessel to occlude. And with some MRI magic, called T1 fat saturated sequence, we can actually image the intramural hematoma. So blood vessels can certainly tear, but they can also become inflamed. And speaking of painful inflammation, giant cell arteritis is a good example. Giant cell arteritis is an inflammatory disorder that affects medium and large vessels. Think aorta and its major proximal branches, especially the intracranial and extracranial carotids. Pain location and quality are once again nonspecific, a recurrent theme here. But palpating the temples may actually be painful because the branches of the superficial temporal artery are often involved. That's why giant cell arteritis is also called temporal arteritis. So, since pain is nonspecific, once again we have to rely on additional features. Nearly one half of these patients experience jaw claudication, pain or fatigue when chewing. I'm sure you knew that, but do you know why? Jaw claudication is thought to be a symptom of hypoperfusion of the jaw muscles, presumably because the external carotid artery branches are inflamed. Involve the ophthalmic artery and vision may be threatened. Blindness is a major and feared complication of this disease. It's the reason why treatment with steroids is started early, even before the disease is confirmed. And thankfully, steroids work. High-dose systemic glucocorticoids effectively reduce the risk of sight loss to less than 1%. And one more thing, just a reminder that giant cell arteritis is a systemic condition, and patients have other systemic symptoms like myalgia, unexplained weight loss, and malaise. You might remember that half of these patients have aching and morning stiffness around the shoulder and hip girdles in the neck and in the torso, which is called polymyalgia rheumatica. The diagnosis of giant cell arteritis ultimately needs to be proven by temporal artery biopsy. But we don't want to biopsy patients unnecessarily. So how do we decide who to biopsy? Jaw claudication, erythrocyte sedimentation ratio over 100, abnormal temporal artery ultrasound. These are all highly predictive of a positive biopsy. Alright, there are of course many more causes of secondary headaches, but we reviewed the most important categories. If you made it this far, you're awesome! But do you have attention span left for one more thing? Yeah? Let's do it. To complete our review, there's one category left, neuropathies and facial pains. Let's talk about trigeminal neuralgia. Incidentally, neuralgia is pain in the distribution of a nerve, because that nerve is dysfunctional or injured. And when it comes to cranial nerves, trigeminal nerve is commonly affected. Trigeminal neuralgia pain is paroxysmal and brief. Patients may complain of dozens of attacks per day. We're talking a duration of attack up to 2 minutes. It starts suddenly, and just like that, it resolves. The pain is often described as severe, electric shock-like, or shooting. The pain often involves the second and third divisions of the trigeminal nerve. Nearly all patients with trigeminal neuralgia describe a trigger. Minimal, seemingly harmless touches to the critical areas of the skin trigger the pain. We're talking about chewing, talking, light touch over the face, shaving, applying makeup, brushing teeth, or even a cold wind on the face. Nowadays, most classical cases of trigeminal irritation are thought to be caused by neurovascular compression. Let me show you what I mean. This is a specialized MRI sequence which images the brainstem in thin axial cuts. For convention, patient is looking towards the top of the screen. And just to orient you, here are the pons, fourth ventricle, and the cerebellum. Here's the trigeminal nerve exiting the pons and minding its own business. But look, what is the structure running across it? This is the superior cerebellar artery. Oh, neurovascular compression. Now I get it. This is an illustration of the surgical view. A small craniectomy is made in the skull, which allows visualization of the trigeminal nerve and the offending superior cerebellar artery. A Teflon pad is then inserted between the nerve and the blood vessel to relieve this compression. Now let's get back to our case. To remind you, this is a 21-year-old woman with history of migraines and polycystic ovarian syndrome and using oral contraceptives who developed constant moderate headache, unlike her usual migraines. She also developed cognitive changes in affect, and left hand weakness. What's the differential diagnosis? Yes, I agree with you, we're likely dealing with a secondary headache. Intracranial or extracranial vascular lesions, for example, cerebral venous thrombosis, cervical carotid dissection, intracranial non-vascular lesion, like a neoplasm, or this may just be evolution of her previous migraines. What imaging studies will help confirm the diagnosis? You might remember that most secondary headache syndromes could benefit from MRI of the brain, especially with gadolinium, and vascular imaging of the head and neck vessels. This patient had an MRI of the brain. This is an axial flare image. Notice the large area of vasogenic edema sparing the cortex. There's a differential for something like this, but perhaps this next study will help us narrow it down. This is MR venography of the brain with contrast. The patient is looking towards the left. What's abnormal? Where is the anterior part of the superior sagittal sinus? That's right. This is superior sagittal sinus thrombosis, and the lesion on the flare is a venous infarction. This young woman received anticoagulation and is actually doing very well. I really appreciate her letting me share her story with you, especially since this is an excellent case of one person having multiple headache types. And now, the moment I've all been waiting for, the 10% of the stock that you should remember. You have a patient with a new non-traumatic headache. Is it a thunderclap headache? Does it peak quickly within 5 minutes? Yes? Then you're dealing with a potentially dangerous secondary headache syndrome. Obtain emergent brain and vessel imaging. Typically, head CT without contrast and CT angiogram of the head and neck with contrast is a good place to start. CT angiogram of the head usually shows the venous sinuses reasonably well, but sometimes a dedicated CT venogram is necessary. Hopefully, early imaging will give you a quick answer. Otherwise, start considering disorders of intracranial pressure regulation, spontaneous intracranial hypertension, hydrocephalus, intracranial and extracranial vascular lesions, aneurysmal subarachnoid hemorrhage, reversible cerebral vasoconstriction syndrome, cerebral venous thrombosis, arterial dissection, giant cell arteritis, and intracranial non-vascular lesions, meningitis, neoplasm. We didn't cover thunderclap headache in this talk, so some of these may be new to you. As needed, you may then proceed to the non-emergent secondary headache workup, including additional imaging with brain MRI with and without contrast, MR angiogram of the head without and neck with gadolinium, MR venogram of the head with gadolinium, inflammatory markers like ESR and CRP, and lumbar puncture. Not all the studies are included on this list, and not all the studies on this list are absolutely necessary. Let the history and examination guide you. If the workup is negative, at this point you have the option of close clinical follow-up and consideration of a primary headache syndrome. If the headache is not thunderclap, it evolves over minutes or hours, then before you start scanning, obtain additional history of current and prior headache episodes. Specifically, the description of pain, timing and duration, frequency, precipitating relieving factors, and associated symptoms. And also perform the neurological examination, including fundoscopy. During your clinical evaluation, snoop for red flags: systemic symptoms, neurological deficits, sudden onset of headache, older onset of headache, pattern change, and provocation with position or valsalva. By the way, patients do clarify their story a bit with more questioning, so if at this point you elicit that thunderclap flavor of a headache, just proceed down the thunderclap pathway. SNOOP positive? Consider secondary headache syndromes. If SNOOP negative, then we're likely dealing with a primary headache syndrome. Consider the duration of these episodes and the headache phenotype. If episodes last seconds to minutes, and the pain is unilateral, electric shock-like, and predominantly affects the lower trigeminal distribution, you're probably dealing with trigeminal neuralgia. In the absence of that classical headache phenotype, some of the more rare trigeminal autonomic encephalgias may present with such brief headache episodes. Episodes lasting minutes to hours with side-lock, searing, severe pain that is associated with agitation, restlessness, and autonomic features are typically cluster headaches. Finally, hours to days of pulsating unilateral moderate to severe headache that is aggravated by physical activity and associated with nausea, vomiting, photophonophobia, and perhaps aura are consistent with migraines. Next, consider abortive therapies. Triptans, NSAIDs, 100% oxygen, non-pharmacological therapies like nerve blocks, and intravenous medications. And if the patient suffers from more than 4 episodes per month, start preventative therapies. Some of the more evidence-based options include lifestyle modifications, antiepileptics, which are particularly helpful for trigeminal neuralgia, antihypertensives, antidepressants like tricyclics and SNRIs, injectable CGRP antagonists and botulinum toxin, and non-pharmacological strategies. Which to choose really depends on patient preference and comorbid conditions. Preventative therapies may take some time to work, so consider a short course of transitional therapy like corticosteroids. And that's all. Thank you for your kind attention. I just have one last mystery for you for today: the cover image. This is a coronal T1 MRI with gadolinium, showing symmetric diffuse contrast enhancement of the meninges. This patient complained of positional headaches that were worst on standing and improved when supine. This is a great example of, on second thought, I'm going to make you figure this out. Happy learning! Bye!